So welcome to today's webinar, which is brought to you by the GenTAC Alliance, which we like to refer to as the research arm of the Marfan Foundation. Our CEO, Michael Weimer, will tell you a bit about GenTAC in a bit. But today's webinar, as you know, is on family planning and pregnancy when you have a genetic aortic condition. We are fortunate to have doctors from both the US and Europe to share their expertise with all of you. We're thrilled that we have more than 250 people registered from all over the world. It's important to us to make the experts accessible to our entire community, no matter where you live. And we know that many of you stay up late to listen to our regular educational webinars. And this year, we're really going to try to do more to make it easier for you that live in Europe or anywhere else in the world to watch these webinars live. This is just the first one, but from seeing the response, I think for sure it's something that we'll be doing more of. Before I introduce you to our president and CEO, I want to remind you that any questions you have for the speakers should go in the Q&A box. Please try to keep them short because I have to read them and to ask them, but also keep them general rather than about your personal experience, because you want to have, ask questions that are applicable to everybody. We don't want to go through everybody's specific personal circumstance. I mean, this is just general medical information, not your personal doctors, obviously. And we'll get to those after all the presenters. So now I would like to introduce you to our president and CEO, Michael Weimer.
Thanks, Eileen. We refer to Eileen as the voice of the Marfan Foundation. We have so many webinars going on throughout the year. I think that's a relatively old picture of me as well. I see popping up there in front of me, but it's nice to see everybody. It's great to have 22 countries represented here. Dr. Kim Eagle, who is the chair of the Alliance, and he's at University of Michigan, unable to be here today. And so I have the opportunity to say hello and do some brief introductions. We're also really pleased to have the Alliance, as I mentioned, as part of the foundation. It's about 2 years ago at this point in time. The goals basically are to advance basic translational and clinical research, educate and support for families and patients and clinicians, and coordinate, facilitate, and encourage the use of biospecimens and data across various registries. A big calling, and I think we have probably over 75 scientists that are physicians and scientists that are directly involved in the GenTAC Alliance. We also have our website now. It's translatable into 11 different languages, so we would urge you to go to marfan.org. We also have a great help and resource center. Wherever you may be throughout the world, you're more than welcome to reach out and be in touch with Jan Lynch, who is our nurse, and I think Eileen will probably show some additional information a little bit later on. But most importantly, thank you for joining us. I agree with Eileen. I think this will be one of the first, maybe the first opportunity we have to do more daytime, seminars or webinars which play differently and to a degree better in different parts of the universe. So we're excited about that. And now let me introduce our speakers. On Preconception Counseling, we have Dr. Melissa Russo from Brown University here in the US. Melissa is also a member of our PAB. We have Dr. Julie De Backer from the University of Ghent in Belgium. She will talk about pre-pregnancy evaluation. And Dr. Martin Colling from Erasmus Medical Center. I hope I didn't do that. I hope I did that some level of justice, Martin. And that's in the Netherlands, and he will talk about follow-up during pregnancy. And then we have Dr. Mary Shepard, my friend from Louisville, who is also with us today. She's at the University of Kentucky, and she's here to talk about delivery and postpartum care. So with that, I will turn it over to you, Julie. You're on mute, Julie.
You should be able to share your screen now.
Yeah, but I think the first speaker is Melissa.
Me.
Oh, yeah. Oh, sorry. Sorry, my fault.
No, it's okay.
Now I will turn it over to Melissa, who is fresh out.
Live TV, that's what happens.
Yeah, it's live. So Melissa.
All right, give me a second to do the sharing screen. I have to narrate always. Sharing. Okay.
And I think the other speakers can shut their cameras off until it's their turn. Thank you.
Okay, you guys see the screen?
You are all set.
Okay, here we go. So you guys know what we're going to be talking about today. So just to orient you, we're going to be talking about preconception counseling, risks of dissection and pre-pregnancy evaluation, care during pregnancy, and then delivery and postpartum care, which I think was just discussed. Screen again. Okay. So just to set the stage with some baseline terms, make sure we're all on the same page. We're talking about pregnancy related to persons who have genetic predisposition for aortic dissection. The aneurysm is when there's a dilation in the aortic wall, which can be at the root or at different places in the aorta. This can make the wall weaker, and then this can lead to a tear or a dissection. And pregnancy is thought to be a higher risk time for a dissection, secondary to cardiovascular changes. So there's twice the amount of blood pumping around the body, which I think other people will talk about. And we think it also may be related to hormonal changes that normally occur in pregnancy, and these can have effects on the short. So one of the most common questions that I get when I'm talking to somebody who's thinking about getting pregnant is it safe for me to have a baby? And really, there's not a quick answer to this. I think there's a lot that goes into deciding if and when to have a pregnancy. And we're going to talk about this today, I think, in all the different talks. There's a lot of detail involved in these decisions, and it's really made on a case-by-case basis on what's going on with your exact medical history and everything.
Melissa, can I just stop you for 1 second? Because people are having trouble with your audio. It's a little bit muffled. Can you get maybe closer?
Yes, let me
That's
try.
better. I think it's a little better when you're closer.
Better?
Yeah, I think so. Everybody's that better.
Is this better?
A little bit. Maybe if you shut your camera off and go really close, so we don't have to see you super close. So.
Somebody put a thumbs up or something, but.
Okay, so that's better. So you're closer. So you're closer. So that's good, being closer. Yes, thank you. Sorry to interrupt you.
No, can you, so some people, can somebody just like put into the chat, if anybody's monitoring the chat, am I clear?
Some people are saying it's better.
Okay, so, I apologize. I don't.
Try to stay as close as you can. Thank you.
Okay, I'll just speak loudly too. Okay, so today I'm talking about preconception counseling. We're going to talk about the one baseline knowledge about your body. So sort of getting imaging before pregnancy. We're going to talk about genetic counseling and heritability and genetic testing options. Talking about multiple methods for becoming a parent, medications to consider that you should maybe come off of or stay on. And then I'm not really going into contraception options, but I can talk about that or answer any questions later. And then the other speakers are going to be talking about risk in pregnancy and prophylactic aortic root replacement. Okay, so prior to getting pregnant, you want to think about a few things. And again, we want to get all the information possible before you get pregnant. We want to look at the entire vascular tree, not just the aorta at the root with an echo. And CT scans are a little bit of radiation, which we try to avoid in general in pregnancy. And so you either need to have a CT scan or an MRA or MRI in the year prior to getting pregnant. Can people hear? Yeah? Is it okay? I can't see anything.
Yes.
All right, I see a little floating thumb. Okay, perfect. Sorry. Okay. And then with this knowledge, you get all your stuff together, and then you're going to see your team even in the pre-pregnancy period. So this involves a cardiologist, sometimes a cardiovascular surgeon, it can be genetics, and then an obstetrician is also really important to see. And if you have not had genetic testing, this is something you may want to consider if you are thinking about doing genetic testing during the pregnancy, because you need to know your genetic variant or genetic change to be able to do genetic testing. And then we'll talk about that you want to sort of get an inventory of all the medications that you're on prior to becoming pregnant. This has to do with your aortic condition, but also any other chronic medications that you're on for medical conditions. Those are all very important to go through just to look at the safety as well. Okay, so other people are going to be talking about risks in relation to pregnancy, more of the cardiac side of things. From an obstetric standpoint, there are studies that have shown maybe that there's a higher risk of preterm birth or preterm rupture of membranes. The question about that is really, are we putting people into labor earlier because we want them to have the baby, or is that a spontaneous thing? And this is just sort of listing out the different conditions. There's potentially a risk of fetal growth restriction, which we'll talk about as we go through the talk. Uterine rupture is more likely seen with vascular EDS, not as much with Loeys Dietz. And then sometimes with Turner syndrome, we can see a higher risk of hypertensive disorders of pregnancy, like preeclampsia. In terms of medication, the first thing I want to say is it's really important to not just stop or start a medication. You should always be doing this with one of your doctors. And we don't want people to just be stopping things cold turkey and not having any alternative plans for a medication. And in terms of how or when to stop medications that I'm going to be talking about in a minute, there's not a hard or finite period, but usually I tell people a transition of about 6 weeks prior to starting to try to get pregnant is a good time. So talking about beta blockers, so those are things like metoprolol, carvedilol, naldolol, atenolol, they all have the alol at the end. Those are generally safe in pregnancy, but we really like to steer people away from atenolol because that medication, when you look at all the beta blockers, there was a study that said that has the highest risk out of the beta blockers of causing the baby to become smaller or fetal growth restriction. In the US, we usually put people on metoprolol. And these medications don't necessarily lower the blood pressure too much because a lot of people will start with a low blood pressure. And the point is really not to control, we want to control the blood pressure, but this is also just decreasing stress on the wall of the aorta, which is why we want people to be on this medication. With beta blockers in general, there's stuff in the literature potentially about the baby getting low blood sugar after birth, or this can cause problems in the baby, but I will tell you that those risks are very, very low. And we think generally if somebody needs to be on a beta blocker for one reason or another, we think the benefits outweigh the risks, and most babies do fine on this. And we use this not just in this population, but in a lot of women that have congenital heart disease or cardiac disease, and it's very, very safe. When we talk about other meds that people can be on prior to pregnancy, the ACE inhibitors like lisinopril, enalapril, and then the angiotensin receptor blockers like losartan and irbesartan, those you want people to be off of those prior to trying to get pregnant because they can cause problems in the baby's kidneys. And then there's lower fluid around the baby, which can then affect lung development. So these are medications we definitely want people to be off of prior to getting pregnant. And then for people that have had an aortic valve replaced or some type of valve surgery replaced where they have a mechanical valve, people can be on blood thinners like Coumadin or warfarin. And this medication we generally want people to also be off of during pregnancy. The red ones are the ones we sort of don't like as much, or the green I put as the ones we sort of prefer. But with people that have mechanical valves, if they do choose to get pregnant, it's sort of we have a one-on-one conversation talking about benefits and risks, because the most concerning thing is if that valve clotted off, that could be life-threatening to the pregnant person. But there can be risks in the baby with this medication where they can be bleeding in the fetus while they're in utero or during delivery. And there can also be a congenital syndrome that occurs where there's facial differences, congenital heart disease, bone problems, and growth retardation. Okay, so changing gears and sort of talking about genetics and heritability, a bunch of people asked prior to this presentation, what is the risk of me passing this on to my child? So most of these conditions are autosomal dominant, meaning that there's a 50% chance every time you have a child of passing this on to them. The most important thing, if you want to do genetic testing either prior to the embryo or on the embryo during pregnancy or in the child, you really want to know what the actual gene mutation or gene change is in the family or the affected person. So again, that's really important. And the ways that we can do testing during pregnancy is on the embryo. If it's sort of made in a dish, we can take a biopsy of the embryo and then implant an unaffected embryos either into the pregnant person, or we can put it into another person, which would be a gestational carrier. And then during pregnancy, we can do testing in the first trimester where we, under ultrasound guidance, take a sample of the placenta. Or in the second trimester, we can do an amniocentesis, and we use a needle under ultrasound guidance to take fluid, which has cells from the baby. With these tests during the pregnancy, there's a small risk of loss. So with the chorionic villus sampling, the risk of loss is about 1 in 300. And then in the second trimester, the risk of loss of the pregnancy is about 1 in 1,000. And then testing can also be done on the baby after delivery. And one of the other speakers is going to talk about that. Okay. So the decision to become a parent, again, is really a personal decision. And then how you achieve this goal is very individualized based on your medical risks, your morals, and your values. Once you decide that you want to become a parent, there's lots of ways to achieve this. Pregnancy with in vitro fertilization or IVF. Again, IVF is a gestational carrier, which we'll talk about. Adoption, or I hear a dog barking, and people can be pet parents or plant parents. And many people can have healthy pregnancies, but this is a very, again, individualized conversation with your doctors. So talking just about pre-implantation genetics, if you do testing on the embryo, it's usually going to be made in a dish, and then at stage 5 or 6, you can take one cell from this trophoectoderm, which is part of the placenta later on in development, and genetic testing is done. The unaffected embryos can be put back into the mother or another person. Again, that's called a gestational carrier. And again, some people choose to have another person carry the pregnancy if the mom is affected, to avoid the maternal risk of carrying the pregnancy with one of these conditions. However, I just wanted to show sort of the legality of this in different parts of the world, because I know we have people from all over the world. So in green, it shows places where people can have either compensated or uncompensated. They're calling it surrogacy, but again, mostly this is, the correct term is really gestational carrier if they're carrying someone else's genetic baby. This is legal in the United States, Western Europe, India, Iran, Russia, Ukraine, and Kazakhstan. And then it can be uncompensated in Canada and Australia. It's illegal though in most parts of Eastern Europe and then parts of Africa. And then there's no actual laws for or against this in Mexico, South America, and China. The procedure of IVF is complex. So just to sort of walk you through what this entails. First, the mother needs to have hormonal medications to induce ovulation, and then eggs are retrieved, and then semen is also gotten, and then you make the embryo in a dish. And again, the embryo is grown for 5 to 6 days, and then a biopsy can be done. These have to be frozen while the process of genetic testing is being done. And then an unaffected embryo can be put either into the mother again or into another person to carry the pregnancy. Another thing just to think about is there are some small risks when you do in vitro fertilization that we think, you know, this is not the place where usually the early embryo is developing, and is there some effects in that? And, you know, we're not really able to parcel out with this in the studies that have been done, if this is inherent to an IVF pregnancy, or is there a lot of people that have done IVF are doing it because of infertility reasons, or is there something with that that makes these pregnancies slightly increased risk for structural abnormalities, especially cardiac? There could be a slightly increased risk of imprinting disorders, which are a type of genetic disorders. And then there's a slight increased risk for adult onset chronic diseases like metabolic syndrome, type 2 diabetes, and cardiovascular disease. But a majority of these kids are really healthy. And then just talking about how do you do this process if you have one of these conditions. There's not really a lot of data or literature out there. There is one case report in the literature about someone having an aortic event while they were going through the process of the IVF. And that was a person who had vascular EDS. But we think that overall, like, you can't really make decisions based on just a case report, and we really need to be collecting more information to understand the risks, if there is risk of any people who want to become pregnant if they have a condition, to, like, if there's risk for them going through this process. The risk of complications from IVF can be decreased if somebody uses, in addition to the hormones to stimulate ovulation, an estrogen blocker or a gonadotropin releasing hormone blocker. The downside to this is you'll not have as many eggs to retrieve, but we think maybe that that's a safer process. The second thing is if somebody that has this condition is then wanting to carry the baby, one embryo should be implanted, not 2 or 3, just to try to ensure as best as possible that it is one baby instead of it becoming 2. It's not foolproof, but that's what our goals are trying to do. So the summary from this first part is really just saying, get information about your body and the risks with imaging and consultation prior to even thinking about pregnancy. Work with your doctors to adjust your medications if needed. There's a 50% chance of passing this on to each of your children. And genetic testing is really optional. It does not have to be done. But if you do want it to be done, it can be done at different stages, on the embryo, during the pregnancy, or on the child after delivery. And there's many different methods to become a parent if desired, and I'm happy to answer any questions. Thank you.
Thank you, Melissa. We'll take the questions at the end. Everybody can put those in the Q&A box, because we do want to have, we do have 3 more presentations. Just want to remind the speakers, when you're not speaking, shut off your video as well as your audio, because we're getting some noises from somewhere else. I don't think Melissa's got a dog there. So thank you. Anyway, now we will hear from Dr. Julie DeBacker.
Yes, hi, I'm just starting to share my screen. Okay, here we go. Okay, so let me first of all thank the GenTAC Alliance and the Marfan Foundation and Eileen and Michael for hosting this this webinar. It's an honor to talk to you this evening. Well, it's evening in my place. So I will be addressing the pre-pregnancy evaluation with you, and there will be, as you will see, some overlap with the other presentations, but I don't think that's a big problem. I even think that's an advantage. And I will be addressing firstly what is the risk that we are talking about, how can we estimate the risk, how can we reduce the risk, and I'll be addressing prophylactic surgery in that respect, and then I will end with the evaluation and some recommendations. Let me just check because my arrows don't seem to work. Okay, here we go. So this has also been already addressed by the previous speaker. So we are talking about the risk of dissection, and as we all know, the main location of dissection in genetic thoracic aortic diseases is the aortic root, but this can also occur at other places. So the root may show an aneurysm, or will show an aneurysm in most cases prior to dissection, and then there's 2 types of dissection. Type A aortic dissection, which is really a surgical emergency with high fatality rates and high mortality rates. And then there's a type B aortic dissection, which is less lethal, but still has high morbidity in the time after the dissection. So in the setting of pregnancy, maternal mortality rate is really high in the setting of dissection, estimated between about 7 and even 25% in some series. So looking at the risk and the estimates of risk, you can look at this from different perspectives. This is in the general population, so showing data on the risk of dissection during pregnancy, because due to weakening of the aortic vessel wall and due to hemodynamic changes with an increased output, there is a risk risk for dissection in all women, a risk of about ×4 when compared to outside pregnancy. The risk is higher for type A than for type B, and it's mostly in the 3rd trimester and in the postpartum period. So pregnancy definitely also in the general population conveys an additional risk factor for aortic dissection. Looking at it from the other way, so from the cohort of patients presenting with dissection, how many of them occur during pregnancy? And this is a really large database, the IAROT database, a database on aortic dissection. So 0.3% of all dissections occur during pregnancy. Looking just at women, about a third of the population, this goes up to 1%. And if you go to the younger women, this number will go up to 19%. So in young women, dissections and pregnancy are definitely related. And this is then looking specifically at the Marfan population. So these are data from the GenTAC registry, where they have calculated that the aortic dissection risk is times 8.4 during pregnancy versus outside pregnancy. So a significantly increased risk, definitely. Type A and type B occur with equal proportions here. And as I will show you in more data, that not knowing the diagnosis is actually the major risk factor for aortic dissection in these women. So risk factors in the setting of Marfan disease and related heritable thoracic aortic diseases. Diagnosis of the aortopathy is really crucial. Most women in series on aortic dissection during pregnancy were not aware of their diagnosis, and this holds true for all the various forms of thoracic aortic disease. Then the other factor that plays an important role is aortic diameter, and this is especially so in the setting of type A aortic dissection, so of the aortic root, where there is a known relationship between the diameter of the aortic root and the risk for dissection. This is not only the case in pregnancy, this is also the case in people outside pregnancy. But the diameter is definitely one of the major risk factors as well in pregnant women. So recognizing women with a predisposition to aortic dissection, knowing the diagnosis, and then counseling them before conception and monitoring the aorta throughout the pregnancy may lessen the risk of this rare complication and improve the outcomes. That was the conclusion of this important paper. So where does this diameter come from? The relationship between aortic diameter and aortic dissection, as I mentioned, is well known also outside pregnancy. But looking specifically at pregnancy, this is one of the first publications on this topic by Reed Peretz a long time ago, 40 years ago or even more, where he looked at diameters and found that in those women with aortic diameters below 40 millimeter, the risk was 1%, whereas it increased 10 times fold in those with diameters above 40 millimeters. So women found to have any aortic cardiac decompensation, so heart failure or aortic dilatation of more than 40 millimeters are counseled against pregnancy, against attempting pregnancy. And this was the conclusion of this old, but yeah, still important paper. And this is where this number of 40 millimeters that is now commonly used actually stems from. So how can this risk be estimated? We use risk estimations, and this is the most widely used risk estimation, the WHO risk estimation, where you have categories going from category 2 to 3, 3 and then 4. 2 to 3 is a moderate risk, and those are women with Marfan or heritable thoracic disease without aortic dilatation. And in these women, pregnancy can go on quite safely. There's a gray zone between 40 and 45 millimeters, and these belong to the class 3. And then class 4 is above 45 millimeters. And in these women, according to the European guidelines, women should be counseled against pregnancy. And then the discussion comes, should surgery be done prior to pregnancy? So how can we reduce the risk? As I mentioned, knowing the diagnosis is really, really paramount. Pre-pregnancy counseling, as Melissa has nicely explained, follow-up during pregnancy, which will be explained in the next talk, beta blockers, as already mentioned, and then the topic of prophylactic surgery that I want to briefly address with you. So there's many papers and many guidelines that where this prophylactic surgery threshold is mentioned. And according to a recent paper, this is what was in the paper, according to American guidelines, it is recommended to have elective surgery if your aorta exceeds 4 centimeters, whereas in the ESC guidelines that were updated in 2018, Marfan women with a prepartum aortic diameter should be considered for elective aortic intervention. But looking into the details of these guidelines, so this is what is in the aortic guidelines from the American Association, and this is what is literally stated: if progressive aortic dilatation and or advancing aortic valve regurgitation are documented, prophylactic surgery may be considered. So this is not a hard recommendation, it's maybe considered class 2B indication, and they're not mentioning the diameter here. There's some mentioning of it in the text, but there's no formal mentioning that above or below 40 millimeters, you should have this surgery. And this is what the ESC guidelines are saying. So prophylactic surgeries should be considered during pregnancy. So not before pregnancy if the aortic diameter is above 45 millimeters. So, I mean, there's this notion of US having 40 millimeters and Europe having 45 millimeters, but really, I think there's this very important gray zone that we should take into account, and we should not fix or focus too much on these diameters. I think, and I think I agree with that with the other speakers as well, that we should go for individualized decisions when counseling women to become pregnant and not focus too much on a number. And this is also illustrated here. This is a very recent publication on pregnancy in women with cardiovascular disease, and you can see that according to the underlying condition, but according to other factors, the numbers that you see in this table, 40, 45, above 40, and then here 42, but there's statements in that table: no diameter is truly safe, and no well-established guidelines. So you can see that we should not really fix on numbers and look at each patient on an individual basis. So even after aortic root replacement, because if you recommend replacement before pregnancy, you should be aware that you are still not in an absolutely safe zone. So these are very limited numbers of cases that have been reported on Marfan syndrome with previous aortic root replacement, and still during pregnancy, problems can occur. Women can still have type B dissection if they have their aortic root replaced. And this is also true for Lewis-Dietz syndrome, where type B dissections have been reported in patients having previous aortic root replacement. So pre-pregnancy replacement does definitely not normalize your risk for aortic dissection, and this should be communicated to couples desiring children. And this is a nice paper from also from Melissa addressing that issue, again mentioning that the risk is very difficult to quantify, but it's definitely not zero, and women should be counseled accordingly. So very briefly, some prospective data, and I'm going to skip this slide because I know that Martijn is going to address this one, but I just want to mention with you that there's data on pregnancy complications in women with Marfan syndrome, and this is one of the more recent ones, where again, they showed that Marfan women with aortic dimensions in a group of 152, so a large group of pregnancies below 4.5 millimeters remain stable throughout pregnancy. In the other heritable thoracic aortic disease entities, you will notice that, again, knowing the diagnosis is really crucial for avoiding dissection. And then to end this presentation, I just want to mention that every woman wanting to become pregnant should have a cardiac ultrasound done prior to pregnancy to look at the root, but also at myocardial and valvular function, an angio or MRI or CT angiography to look for distal aortic disease. They should be referred to the anesthesiologist, and in this particular case, dural ectasia should be looked for because this can affect the anesthesia, the dural anesthesia procedure during the delivery, and inform people. So talking. I think you cannot talk too much on this issue. These are some recommendations that we have issued with the vascular group. So again, do not focus too much on this diameter. There's a tendency to say that pregnancy is safe well below 40 millimeters. There's this gray zone between 40, 45, and above 40, you should be really very careful. There's limited evidence out there. So I want to conclude that pregnancy confers a risk for aortic dissection in the presence for aortic disease, of underlying disease. Most dissections, and this is really the key message that I want to bring, occur in women that are not aware of their disease. The outcome is better when they know it and when special care is initiated. And pre-pregnancy aortic root replacement does not normalize your risk. Size is just one piece of the puzzle, and really an individualized approach for each single woman is really mandatory, and there's definitely a need for further study there. So I want to thank you for listening, and I'll be addressing questions after the talks. Thank you.
Great, thank you so much, Julie. And just a reminder, so if you have any questions, put them in the Q&A box. We're going to address them separately afterwards. Our next speaker, who's going to talk about follow-up during pregnancy, is Dr. Martin Colling from Erasmus.
Yeah, sharing my screen. Hope it's visible for everyone. Thank you for the introduction. It's really a pleasure to speak here today. And I will continue this webinar with the next topic, the follow-up during pregnancy. So in the coming minutes, I will discuss when we should see our pregnant patients and who actually should see them, discuss some aspects on echo and MRI during pregnancy, and I will conclude with a topic we actually prefer to avoid, of course, during pregnancy, and this has discussed some aspects regarding surgery. So, as has been addressed by the previous speakers, we know that pregnancy with aortic pathology has an increased risk for complications, and it should be managed in expert centers. So it is very important that these cases are managed by a multidisciplinary team. So we need at last a high-risk obstetrician, an anesthesiologist, but also a cardiologist with specific knowledge and expertise. So if necessary, as can be seen on the figure on the right, we can actually extend this team with all kinds of other specialists, like the ICU team or geneticists and so on. But because of this great variety in pathology, as has already been addressed by the other speakers, a really individualized approach is mandatory, and topics that must be addressed are both preconception counseling, but of course also the management during pregnancy and delivery. And of course, and this is very important, delivery of high-risk pregnancies should be done in hospitals with the availability of cardiothoracic surgery. So there is an increased risk for aortic dissection in pregnancy, which is the result of both hemodynamic, hormonal, but also thromboembolic changes. And actually, pregnancy itself is a challenge for everyone's body, and it causes a significant increase in the hemodynamic demands, as is visualized on the right. And as you can see, these adaptations, they start early during pregnancy, and then remain fairly stable during the second and third trimester to peak during delivery. And furthermore, some observational studies in non-aortic disease patients has shown that in pregnancy, there's a general increase in the aortic diameters. And this is most striking during the third trimester and postpartum, and most outspoken in those patients who already have hypertension or become preeclamptic. However, there is conflicting evidence regarding the question if the growth of the aorta is potentiated in pregnant Marfan patients, because some studies reported growth with partial recovery postpartum, while others found no significant differences in patients with and without pregnancies. So we believe that careful follow-up is indicated in all these patients. So patients with aortic pathology should be overseen in specialized centers and supervised by both cardiologists and obstetricians who are actually aware of the potential complications that can happen in this patient category. And again, there should be an individualized approach that is based not only on aortic dimensions, but also on diagnosis, and is overseen by this multidisciplinary team. So in most patients, we prefer to perform the diagnostics by repeating the echoes for the follow-up. And of course, the frequency of this echo actually depends on multiple factors, like the underlying diagnosis, the severity of the aortic dilatation, and of course, also the increase in aortic diameters during pregnancy. So in all patients with aortic dilatation, the echo should be repeated every 4 to 12 weeks during pregnancy, and it should be extended postpartum. And especially in those patients with an aortic diameter of more than 40 millimeters or with progressive dilatation, specific consideration are necessary. So, and if we believe that there is aortic enlargement in the parts that we cannot assess correctly with echo, then of course, we have to clearly think about making an MRI in these patients. So one of the previous speakers already discussed the use of the prophylactic use of beta blockers in pregnancy. Well, some studies actually observed a reduced rate of progression of aortic dilatation. So according to the European guideline, it should definitely be discussed in all patients to start them during pregnancy. However, it's not totally clear. So the final evidence for this subject is actually lacking. Well, and in case, of course, patients are using ACE inhibitors of ARBs, which are contraindicated during pregnancies, these patients should be stopped and switched to beta blockers, which can be started as soon as they stop with contraceptives. And as one of the previous speakers already addressed, there were some concerns about the effect of the beta blockers on fetal growth. Or if you look at the most recent data from the ROPEC study, it was actually not seen. However, it was seen in some smaller studies. So still, we think there's a clear indication to monitor the fetal growth during pregnancy when the mother is taking beta blockers. So does it pay off? Well, there are few studies who actually evaluated the safety and the course of pregnancy in patients who are treated according to the current guidelines. And I think the ROPAC is a very important global prospective initiative in these. It is a global registry in more than 5,500 patients with pre-existing cardiovascular disease. And in one of the sub-studies, in 189 patients, they evaluated the course of the pregnancy. And half of these patients were patients with Marfan syndrome. And actually, in the entire group, there were 4 dissections, 3 type A dissections, and 1 type B dissection. And again, none of these patients actually were aware of their diagnosis prior to pregnancy. So fortunately, there also was no mortality in this cohort. And one of the main conclusions of the authors of this study was that if the overall pregnancy outcomes in women with thoracic aortic disease, if they're followed according to the current guidelines, are good. And they really underline the importance of adequate preconceptional counseling. However, in other studies, a much higher incidence of dissections during pregnancy are reported. So we definitely need more prospective studies to evaluate this question more extensively. So all our patients with aortic disease should be seen on a regular basis throughout the pregnancy for evaluating the aortic root, and echocardiography is the preferred diagnostic tool in these patients. So as we all know, it's safe, it's easy to use, and it's widely available. So it's the most important diagnostic tool in pregnancy. And most importantly, it does not use any ionizing radiation, so there are no reports on adverse fetal effects for the diagnostic use of sonography. So in the case we suspect that there is dilatation of in the parts of the aorta we cannot correctly assess with echo, then we should use an MRI scan. And again, by using this technique, there are no reported biological effects of MRI on fetuses. However, if there is a case of a suspected acute aortic dissection, then an MRI can take too long. So in these situations, we definitely need to use the CT scan to quickly come to the correct diagnosis. So I will continue with the final part of my presentation and discuss surgery during pregnancy. And of course, this is something we want to avoid. But unfortunately, still it is sometimes necessary in case of an acute type A dissection in which emergency surgery is indicated. And which is also true for patients who are not pregnant, this procedure still has very of a high maternal, but also fetal mortality. However, not performing the surgery, of course, is almost never an option. So the second indication is non-emergency surgery. And this complex decision is always complex and should be made after a thorough discussion on a case-to-case basis. And it should be considered according to the European guidelines in patients with a dilated aorta with a rapid increase in diameter. But usually, fortunately, there is always time to discuss the risks and benefits in the team and of course also with the parents. What do we know about the outcome after aortic dissection? Julie already showed you some data of the IRAD registry, and it's this registry they assessed the outcome in 29 pregnant patients with a dissection. And in this cohort, there was an in-hospital mortality of 3%, which is actually rather low. And unfortunately, in other studies, a much higher mortality of up to 24.6% is being seen. So it's actually still believed, which is also clear from the other reports, that there is still a substantial mortality after maternal dissection. So if we look a little bit in more detail to elective surgery during pregnancy, the outcomes have improved, with in some studies reporting an equal mortality as in non-pregnant patients. However, again, in other studies, a much higher mortality was reported. Regardless of this maternal mortality, there still is a high risk of fetal complication and death. So there's still a lot of debate going on about what is the best timing for elective surgery during pregnancy. And if, again, we look at the European guidelines, they recommend to perform the semi-elective surgery to be performed between the 13th and the 28th week of gestation, while others advise the third trimester to be the most optimal moment to perform surgery. Although, of course, this really, again, depends on the specific characteristics of every single case. This last question about timing has been evaluated a little bit in more detail in this recently published meta-analysis. And in this analysis, they analyzed 386 patients. Most of them operated with urgent or emergency indication, and 31% of them because of aortic dissection. And what they saw was the timing of surgery had no statistically relevant impact on the maternal mortality. And also C-section prior to surgery did not significantly affect the maternal mortality. So the authors concluded that clinical condition really is key in guiding the decision when to operate. But on the other hand, if we look at the fetal outcome after surgery, we can see that in the third trimester, there's the lowest mortality, although this is not statistically significant. But on the other hand, if a C-section was performed, and of course, most of these cases are in the third trimester, but if this is performed before surgery, the fetal mortality is significantly lower compared to no C-section before surgery. So the main conclusion of one of the conclusions of the authors was that it should be considered to perform a C-section if the fetus is viable. So to conclude, I would also make discuss some aspects of pregnancy in patients with Lewis-Dietz syndrome, although the data is much scarcer in this group. And of course, we know that the risk of aortic dissection during pregnancy is increased, although the evidence of complications in different studies shows a wide variety. And again, it is most common during the last trimester and postpartum. So the same considerations regarding beta blockers apply, although some advocate that to continue the use of ARBs until there's a positive pregnancy test. So again, overseeing a pregnancy demands a multidisciplinary approach in an expert center with regular follow-up evaluating the aortic dimension. And also for this particular patient group, prophylactic surgery should be strongly considered in patients with an aortic diameter of 45 millimeters or with rapid growth. And again, it should also be continued to evaluate these patients after delivery has taken place. So I came to my final recommendations, and as we have seen that pregnancy in patients with aortic disease should be managed by a multidisciplinary team and an expert center, and it's crucial to see them on a regular basis, both throughout pregnancy as in postpartum care. So echo is then the most important diagnostic modality in these patients, and the frequency, of course, should be determined on a very individual basis. As we have seen that aortic dissection during pregnancy still has a substantial maternal and fetal morbidity and mortality. And on the other hand, if surgery is performed in these patients and there is a viable fetuses, the Caesarean section prior to surgery should strongly be considered. Thank you very much for your attention. And if there are any more questions regarding the treatment during pregnancy, I'm happy to answer them afterwards.
Great. Thank you so much for that presentation. It's really, really great stuff for everybody. So our final speaker tonight is it's tonight for you guys, not for me. Dr. Mary Shepard from University of Kentucky, who's going to talk about delivery and postpartum care. All yours, Mary.
Sure. I can't share my screen right now.
Oh, Martin, you'll have to stop sharing on your end.
Wonderful. Thank you. As introduced, my name is Mary Shepard, and I'm happy to be here to talk with you about delivery and postpartum care. I tried to build this chart as a nice summary, basically making a distinction amongst the aortopathies in which we would do a differential management. So first, let's just consider basically all aortopathies except for vascular Ehlers-Danlos syndrome. Currently, we could consider vaginal or Caesarean delivery, and a lot of this will depend upon aortic root size, as well as the resources of the individual institution where the delivery is being done. However, it is important to say that vaginal delivery can be an option. And as Dr. DeBacker alluded to, whether there were going to be recommended prophylactic aortic root repair can depend on country even, but this would generally be done. A vaginal delivery only considered if the aortic root is known to be less than 4 or 4.5 centimeters. Currently, regional anesthesia would be recommended, and we'll talk about what that entirely entails, and also an operative vaginal delivery or an assisted vaginal delivery, which can minimize Valsalva, and this could include use of forceps or vacuum delivery. In general, we plan delivery at 39 weeks, but there's no entire consensus, and this can range from 36 to 39 weeks of gestation. So that's Marfan's, Loeys-Dietz, Turner syndrome, familial thoracic aortic aneurysm dissection, bicuspid aortic valve. We treat patients who have vascular Ehlers-Danlos syndrome a little bit differently. For them, we would recommend Caesarean delivery. And this is to offer special attention to the tissue fragility. And right now, there's no evidence to recommend what some people would maybe consider as a prophylactic agent to try to reduce bleeding, such as desmopressin or tranexamic acid. And generally, also, those Caesarean deliveries will be planned at an earlier age of gestation, 34 to 37 weeks. I wanted to just try to illustrate and simplify what we're talking about between these different types of anesthesia. So general anesthesia would generally require intubation and mechanical ventilation. But with regional anesthesia, you can place a needle onto someone's back, and where that needle exactly is placed in the spine helps us to distinguish between what would be considered an epidural injection or a spinal injection. As you can see here, the catheter is threaded outside of the dura. This really thin yellow line is the dura, and inside the dura is the spinal fluid, which is brown. And what you see in the big yellow cord there, that's actually your spinal cord. So an epidural injection is going outside of the dura and placing the anesthetic in that epidural space. And that's different from a spinal injection because at that time you're going through the dural layer and actually injecting the anesthesia into the spinal fluid. And that has a number of different ramifications. The spinal anatomy, which differs based on the genetic aortopathy that a person might have, can impact the anesthetic choice. And these are a few examples. Dural ectasia is an anatomical variation that increases risk, that you have an increased risk of manifesting if you have Marfan syndrome or Loeys-Dietz syndrome. One way to assess for this would be an MRI of the lumbar spine. And what you can see here is that you have scalloping of the vertebra. And that's actually an expansion of the spinal fluid within the dural sac at the lumbar spine in a person who has maybe Marfan syndrome, or also can be Loeys-Dietz syndrome. This increased volume of spinal fluid at the base of the spine can impact the efficacy and dosing of spinal anesthesia. And this is one of the reasons why we recommend assessment with imaging in advance of pregnancy, as well as consultation with an anesthesiologist before delivery. Now, cervical instability is another spinal manifestation that has an increased risk in Loeys-Dietz syndrome. This can be assessed with an X-ray of the cervical spine and flexion and extension. As you can see here on these lateral views, the position of the vertebrae in relation to each other changes if there's instability. And you can see that when the person moves their head forward and backward. This impacts intubation. And that's an initial step that's necessary generally to administer general anesthesia. And this is a picture I wanted to show you that just in the normal supine position, your vertebrae are in more of a natural alignment. But intubation requires something that we call the sniffing position. That changes the axis such that you're straining the alignment of the cervical vertebra. And you would not want to do this if you knew that someone had cervical instability and you could possibly disrupt that natural alignment. Another spinal manifestation includes scoliosis, and that affects anesthesia choice. And there's an increased risk of scoliosis in people with Marfan syndrome and Loeys-Dietz. This can be assessed with X-ray, seen here. And this is important because it can impact lung capacity. For example, if you're on mechanical ventilation, it can also affect access to the epidura. There are diffuse vascular anomalies that can occur in any of these conditions, but most notably an increased risk in Loeys-Dietz as well as vascular EDS patients. This can also impact the delivery method that's chosen as well. Overall, the majority of aortic complications occur in the third trimester, but it's also the postpartum period, and that's something we haven't discussed at all yet. So what should we do to help minimize risk during the postpartum period? First of all, we would recommend inpatient observation for at least 48 to 72 hours, and that can depend based on the mode of delivery as well as the country. And we recommend imaging prior to discharge, and this can depend a little bit based on the patient's circumstance. But generally, an echocardiogram or a CTA/MRA. And depending on the circumstance, if, for example, prior to discharge, we've only done the echocardiogram, then I'm going to usually get the CTA or the MRA in the postpartum period, 3 to 6 months after they've been discharged. Alternatively, if you had the CTA or the MRA in the inpatient unit before discharge, then I would maybe do just the echocardiogram at 3 to 6 months postpartum. we have some really great data, and this has already been outlined a little bit by the speakers prior to me, where we're basically quantifying this and trying to accumulate the data from multiple centers so that we have the granularity to detect and calculate really what type of risk and what situation is happening postpartum. But one area of risk that has been focused upon is breastfeeding. So oxytocin is a chemical released endogenously in each person that stimulates both labor and lactation. Oxytocin levels peak during both the delivery and the postpartum period for that reason. Delivery because of uterine contractions that are necessary, as well as postpartum period if someone is lactating. Studies in a mouse model of Marfan syndrome demonstrate the detrimental effect of oxytocin. And you can see that here, and this is a paper that was published by Dr. Dietz and his group, showing that basically the oxytocin was a risk factor mediating dissection, and that when you remove the pups from the breastfeeding mothers after delivery, that the risk of dissection decreased. However, the question is, does this mouse data still apply to humans? And we have just this recent JAC publication in which we've had some basically pooled data to look at this question. It included women who had Marfan syndrome, so not the other aortopathies, who had ever been pregnant. And that was a total of 152 pregnancies for 112 live births. And this was in a total of about 74 women. What they found was that further studies are needed to establish whether lactation increases the risk of postpartum aortic dissection, as seen in the experimental animal models. So the summary there is that we still don't know for sure how well the mouse data extrapolates to humans, and we need more cases to maybe possibly have the power to detect the difference if one is there. Now, another important thing is that postpartum, you have both mom and baby. And so we're going to shift our attention to include the well-being of the child and their genetic risk. So as our previous speakers mentioned, there's, in most of these autosomal dominant conditions, a 50% risk of passing the mutant allele to offspring. And so if you have already identified a mutation in the family, you can just look for targeted testing in the child. Sometimes you don't already have that information, and you might do a broader full sequencing, deletion, duplication analysis in either a single gene or even a panel. But what I've had as my experience is what really concerns families when we know that testing needs to happen is what stage do we collect the blood and test in the children. So you can actually collect cord blood, isolate the fetal DNA, and find if the mutation is present. And we've done that at our university in conjunction with our wonderful high-risk maternal fetal medicine attendings. It's also possible, and usually, you know, if possible and access to a pediatric phlebotomist, you can do a heel stick. You basically use a capillary tube to collect blood from the baby's heel. And when they're a little bit older, or if you have a pediatric phlebotomist who specializes in very small infants, you can do a venous blood draw from the antecubital area. In summary, most women with all connective tissue disorders have favorable outcomes in pregnancy. However, the diagnosis prior to pregnancy, proper surveillance, and management by a multidisciplinary team help to ensure a good outcome. And that's really the goal of everyone who's here and participating in this panel, is that we want to help get the information out to have safe deliveries and enable as many people who want to have children, despite the fact that they might also have an aortopathy. Thank you.
Thank you, Mary. Thank you to all our speakers. That was really great. I know we have more than 100 people still here listening to the whole thing, so that's really great. We're going to go right to the questions. So if you can stop sharing your screen, Mary, and then we can have all the speakers come back on video. I won't put my video on because you don't really need to see me. Well, you all have to be nice and big. All right, we'll start at the top here. Do any of the speakers have experience or insight with patients who have fibrilin 2 variant of uncertain significance? Anybody want to take that? Or maybe that's a no. We don't have data. We don't have data. Okay, we're going to come back to you, Jane. Save that question for another day. Here's another question. Could you explain what it means for the maternal mortality rate to be 20% with beds? This was early in Melissa's slides. So I guess that's for you, Melissa.
Yeah, I mean, that was based on some previous studies done with Peter Byers' group and Misty Murray. I'm not sure if you want me to explain like why people died. People have passed away secondary to having a vascular event during pregnancy. It can be having bleeding during the delivery. Potentially people have died from rupture of the uterus or rupture of like hollow organs such as the spleen or
okay. Thank you for that. There's probably more information on that from the VEDS movement. I think there's some more information specific to VEDS and pregnancy there as well. Do you have any women with Marfan who have also received a mechanical heart valve and are on blood thinners carrying a baby to term? Somebody want to take that? Julie's nodding. Do you have an answer for that?
Yes, I mean, I can answer that. We have had women with mechanical valves going and with Marfan disease going through pregnancy. As has been mentioned by Melissa in her talk, this needs to be addressed well ahead of pregnancy. There's the detrimental effects of the anticoagulants that are needed in women with mechanical valves, but there's algorithms, there's schemes that we can use for that purpose. What is important to know is that the teratogenics or the negative effect on a fetus is dose dependent. So women who can have proper anticoagulation on relatively lower doses of anticoagulants can actually continue being on their regular anticoagulant regimen. In those women who need or who require higher doses of anticoagulants in the initial phase of pregnancy, you will need to switch. So you will, and there's options. There's options to go for low molecular weight heparins, which are known to be less effective in avoiding thrombosis, but still, I mean, there's a balance that you need to make there. But it is possible, and what is important if there's a switch needed for low molecular weight heparin. So these are the injections that you get. So I don't know, we have Fraxiparin. I don't know if the names are similar in other countries, whatever. These are the small injections that you need. And what is important is that the dose is monitored. So you need to monitor the level of the injections regularly. And this is also according to schemes. But well, the short answer to the question is yes, it is possible to go through pregnancy with a mechanical valve. It's high risk, definitely, but it is possible.
Thank you. That was a great answer. My grandma and my mother both had aortic aneurysms, but later in life, years to decades after having children. So can childbearing pose a risk that much later in life, or were the aneurysms probably unrelated to pregnancy? Mary, you're nodding. Do you want to try that one?
I think it's a great question, and I would say that it's not clear yet. We know that for even the general population, that different events and complications during pregnancy can affect risk 20, 30 years down the road for a lot of different things, including the risk for developing diabetes if you have gestational diabetes. And so those are the things that we really don't have great data for yet, including in this field. And part of the reason is because a lot of the studies, that we get funded for, we only have a max 5-year period. So how do we know the impact of how someone's pregnancy might cause development of aneurysm 20 or 30 years is challenging, and people are becoming more aware of it, and we're going to start to hopefully have better answers for you.
Great. Thank you. Here's another question, this one about multiple births. Are multiple births, like twins or triplets, higher risk for a woman who has an aortic disease? Anybody?
So we can talk about that.
Melissa, why don't you make comments on that?
So I would have to say that, so data-wise, I don't think that we have the data. They haven't looked at people that have had like singleton versus multiples and seeing if there's a higher risk, but we know that the physiology is that when you have twins, you have risks of a lot of other things, like higher risk of preeclampsia, gestational diabetes, the heart stress and strain is more than if you have one pregnancy. And so I think the thought is, and I sort of mentioned that in my talk, that you really, if you're in charge of putting back one embryo or two embryos, we really try to avoid twins and triplets because we think that that's probably more stress and strain on the pregnant person if they are the one that has that predisposition for dissection.
Great, thank you. Thank you for talking about that. I just want to comment here. Carolina is asking about options for family planning because it's her son who has Marfan, and we didn't really address all of that here. We did a little bit, but we do have other materials on the different options for having a family on our website and our YouTube channel. So I just don't think we have a lot of time to into all of that here. Can somebody address if the risks change depending on the exact mutation you have? So the studies that you've all presented, do they take different mutations into account? Somebody want to handle that?
I would just say that right now, again, this is an area of discovery, you know, and even like I lumped Loeys-Dietz syndrome together. We know there's multiple subtypes, and those are all mediated by mutations in entirely different genes. So as we are accumulating more patients and we're having larger studies, then we can say, what's the risk for type 1 versus type 2 versus type 3, right? And I hope that that's also the next stage following that is, what about a nonsense versus a missense mutation in collagen 3A1, right? What about a mutation in this exon of the FBN1 gene versus that exon? And I do think that the risk will be different, but so far we don't have enough detailed information to be able to make specific recommendations based on that.
Okay, I think we're getting a lot of great questions here for future research that will have to come back in many years and answer. I'm going to ask this one for Martin because he hasn't answered any yet, and he talked about follow-up during pregnancy. Somebody's asking if the risk of miscarriage has increased for women with Marfan. Any experience or data with that?
I am not aware of any data of that. In my clinical experience, I don't have the impression that it is. I don't know if my other colleagues know any data on it, but I haven't it present at this moment. I see them signing no.
I guess that's the answer. No data on that. If you go through genetic testing on the embryo, is there any way to remove the LDS gene? Okay. Melissa, you were pretty emphatic on that.
Yeah, I mean, so the main thing with all of these is that you need to know what exact mutation you're looking for. And if that is known, then it can be looked for in the embryo. So it can be done with any of these conditions, but the key is really knowing the actual gene change in the family. And just, I should have put something in there, and I know when I was originally making my slides, with just the father. So you can do this whether the mother or the father is affected with the condition. It's not just for females. It could be any person who is trying to sort of test the embryo, and it could be coming from the male or the female. So
there's another question about that, but just to put it in a nutshell, when you do that, is that 100% accurate?
Nothing in genetics is 100% accurate.
I knew you were going to say that.
Yeah, I mean, but really we're biopsying, again, the placenta tissue. You don't biopsy the actual embryo. And 99% of the time that is accurate. Anytime you do this kind of testing, diagnostic testing during pregnancy is always recommended, but I would say a majority of people that go through this, we feel pretty comfortable that it is, you know, as accurate as it can be, and we don't necessarily recommend people have to go through that second test while they're pregnant because there's risk of fetal loss. And so a lot of people will just do the testing on the embryo.
Thank you. We're going to do just a couple more because we're kind of over on time, but there are such great questions in here. Is it safe to get pregnant if you have a NUSBAR implant from pectus excavatum repair? Do I have to call on somebody? You feel like the teacher. Melissa, any experience with NUSBAR in women?
I don't know if anybody else wants to speak up.
Okay.
I have not myself had someone. I don't think that would necessarily be a problem during pregnancy.
I think a lot of these questions are very specific. So unless there's data and scientific work done in this area, anything else is just anecdotes. So I just want to explain that to people.
Correct.
It's not that doctors don't have experience with it, but part of talking about this and presenting this information to you all is really based on scientific data and research. And so, any one-off experiences might not be helpful and may be unhelpful. So that's why you're getting the answers that you're getting. I just want to explain that to everybody. We'll take one more.
I think Mary was going to say something.
Oh, go ahead. Mary, did you want to answer that?
Yeah, for that question, which is awesome, because now I'm going to be thinking about this and looking for that data. But one reason why a lot of us probably haven't seen that yet is because the women who are of childbearing age right now, if they had pectus excavatum, for example, in the 80s and 90s, a lot of them had the Rabbit procedure. And so the NUSBAR wasn't in place, and we're going to see that with the next generation now.
Okay. And one more question here. If the sample, you talked about taking the sample from the cord or from the placenta, is taking it from the cord better to for diagnosis or is the same or equal with the placenta?
Well,
blood, right?
Well, I would say, I wouldn't necessarily consider the umbilical cord different from the placenta, right? So if you're doing a delivery, you're going to be taking fetal blood from the for the umbilical cord, and then you're going to look at umbilical vein. You have the ability to distinguish maternal blood circulation from fetal, and you want to make sure you get the fetal DNA. We wouldn't necessarily retrieve blood directly from the placenta itself.
Okay, excellent, thank you. So there's a lot of really great questions here. If you need an urgent answer to these questions, you can, I'm gonna just share my screen here for a second. Hopefully you can see that. You could send those questions. Can you see Jan Lynch on there? Can you guys see Jan? Yes, okay. That's Jan Lynch, who's in our help center. And that's the URL for the website where you can submit your questions to her. But these questions, like I will grab these questions and maybe we can answer these on our social media as well, or in a Q&A in our blog or something, because there's a lot of really great questions here. I do want to point out that if you email or submit a question to Jan through that website, you could do it whatever language that you want, because we have language lines, so it can be translated. So if it's easier for you to do it in a different language, feel free to do that. Before we thank our speakers, I want to share a few more things here coming up. We do have more webinars coming up on research, and we know you all wanting to know what's new in these areas. So we have physical activity and exercise, and we heard back in Paris at the scientific meetings a lot of new data coming out on exercise with Marfan Lowy seats and beds, and that's going to be presented by Alan Braverman from WashU and Siddharth Prakash from Texas. Dr. Hal Dietz will be with us in February to talk about genetics research. Dr. Enid Neptune from Hopkins will be here in March to talk about lungs, and Dr. Jefferson Doyle, also from Hopkins, one of our recent research grant recipients, will talk about some recent eye research. Of course, we have 2 webinars coming up next month and in November about the A2 clinical trials on a potential treatment for VEDS. I think the November 21st webinar is actually in the afternoon. So all of you in Europe, that might be a good time for you. So we'll send those links along to register in the follow-up email that we have coming out. Also, I want to point out our Walk for Victory program, and you are all over the country. So I want to point out the Global Walk for Victory, which is virtual, and it'll be a great place to meet people and, you know, represent your country. I know we have, after meeting people over in Paris, from Ireland, I'm going to have Team Ireland. We're going to have, you know, Team UK. We're going to have Team Germany. So feel free to represent your country and get involved with our Global Walk. If you go to marfan.org/walk, you'll see that there. We have a fun online party, great chance to meet people. I want to point out also, we have some other virtual events coming up. The VEDS Birthday Bash is virtual on October 6th. And for anybody here who is a Spanish speaker, we are doing a half-a-day Spanish summit on January 21st. It's a Saturday morning here. So wherever you are in the world, hopefully that timing is okay for you. And that will all be in Spanish. You will not hear my voice that day. I think I did enough today anyway. And then other events, obviously, we have in the US that you are all welcome to come to. I do want to thank our speakers, and you know, Michael, if you're still here, thank you for being here. Do you all have any final words, Mary, Julie, Martin, Melissa, any final words that you'd like to say to people that we have left here, which is obviously over 75 people still hanging out with us? So.
No, other than thank you, Eileen and Michael, and thank you for my colleagues. I enjoyed very much, so no other words than thank you.
I want to say, for, you know, Julie, I want to thank Vascular. You've seen their logo on the bottom of many of these slides, and Vascular has been a really great partner to the Marfan Foundation. They're the European Reference Network, and we work closely with Julie and some of her colleagues over there. So we want to thank Vascular for being a great partner to the Marfan Foundation as well.
It's a pleasure. And Martin is also a member of Vascular, and I just want to mention, so there's the two of us.
Thank you. It was nice to meet you for this, Martin. Thank you for joining.
Yeah, it was a pleasure. Hope to see you in the future.
We will do more. We'll come to the Netherlands.
I hope so.
Melissa, thank you for taking the time between babies today. Michael, any final thoughts?
No, it was great. Thank you all very much for participating. Wonderful, wonderful afternoon.
All right. Have a great day, everybody, and a great evening. Take care.